Okay, so we're going to talk about sepsis is a inappropriate immune response to some sort of infection. Okay, generally it's a bacterial infection with gram-positive organisms, right? These are going to cause worse outcomes because when they die, they're going to release an exotoxin, which is going to amplify the hyper response of our immune system. Sepsis can also be from a fungus or from a virus. Okay, and it's going to result in this life-threatening organ dysfunction, right? Dysregulated response to infection, okay? Hyper response to an infection. Pro-inflammatory cytokines from our innate immunity, as well as like neutrophils, will flood an area. They're going to cause massive systemic inflammation. Our body's going to become overwhelmed. We're going to have massive peripheral vasodilation, capillary permeability, which is going to shift fluid outside of our blood vessels and into our third space. And then this can also cause our circulatory and metabolic dysfunctions, right? Because we're going to not have blood flow like we need it to. We can end up with MODS, or multiple organ dysfunction syndrome, and this can also lead to DIC. And so SIRS is a little bit different. So SIRS is a systemic inflammatory response syndrome. So it's an exaggerated defense of some sort of noxious stressor. So we can have this also from an infection, from trauma, from surgery, acute inflammation, ischemia. So if we think about like after an MI, cancers can also cause SIRS. So we have excessive pro-inflammatory response. And then we'll also have a major anti-inflammatory is deactivated. So our checks and balances that help mediate inflammation are no longer present. And so SIRS can then lead to sepsis. Okay, so sepsis is a worse version of SIRS. Here is a SIRS screening tool. Okay, so it's going to tell us if we have systemic inflammation, whether it's infectious or non-infectious. Okay, so this is going to include if they're febrile or if they're hypothermic, tachycardia, respiratory involvement, right? Do we have are we tachypneic? Are we also have like a low CO2, right? Are we breathing off all of our CO2? And then do we have leukocytosis or leukocytopenia? So sepsis, you hear about it a lot because it's the third leading cause of death in U.S. hospitals. High rate in 2018, and then continued to increase probably because of COVID, but it's a very high mortality rate. 20 to 50% of people die in the hospital, and then this mortality rate also increases post-op, right there, or post their hospital stay. Their year mortality rate is also very high. So what's happening in sepsis, right? So we have an inappropriate immune response. Okay, so inflammation from our innate immunity, okay, pulling in pro-inflammatory cytokines and neutrophils to attack whatever it is that triggered the immune system. But the system that normally like deactivates our pro-inflammatory system is told to stop. Okay, and then this inflammation is just going to continue and continue and continue and spread and spread and spread and spread. These pro-inflammatory cytokines, they're going to cause capillary permeability, okay, so through vasodilation and endothelial damage, they are allowing our capillaries to just seep out fluid. So we have third spacing, so we have a distributive shock because fluid is where it's not supposed to be. Okay, it's in the extravascular space. We're going to have hypotension because of decreased or like blood vessel tone. Okay, so it's going to have dilation of our blood vessels. And then that endothelial cell damage not only allows for capillary permeability, but it's also going to cause cell damage, which is going to cause these little microclots. Okay, so I'll have a hypercoagulability with these micro blood clots. But then, if all of these micro blood clots go unchecked, we're not going to have enough clotting factors or platelets, which can then lead to disseminated intravascular coagulopathy, where then our patients are unable to clot and will bleed profusely. So what do these guys look like? So we have early sepsis, which early sepsis is going to be our stable. Gosh, A, B, L, E, and we are stable because we have a normal blood pressure, okay? Normal blood pressure. Unstable, I'm gonna just put US. Unstable is going to be a systolic blood pressure less than 90. We are then in unstable sepsis. Okay, or unstable shock anytime we're less than 90. So again, some of our early, more stable septic findings: tachycardia, bounding pulses, right? Because we were trying to compensate. Flush skin, sort of vasodilating. Febrile, they'll be warm to the touch. Okay, changes in level of consciousness, and this can just be that they're more tired. They're harder to stay awake. They might be just a little bit confused. And then decreased urine output. So urine output less than 30 an hour. Or less than 0.5 to 1.5 mils per kg per hour. Mils, oh my goodness, per kg per hour. Excruciating. Okay. Where we're unstable, okay, unstable is going to be cool, clammy skin, right? If we're not perfusing well, we're unstable. Weakened thready pulses, again, still tachycardic, systolic less than 90. They can be febrile or they can be hypothermic. Lethargy, coma, okay, they're super hard to arouse, they're very confused, not making any urine, or signs of a decreased cardiac output. So prolonged cap refill times, cardiac output less than 5, those types of things. And so some different ways that we can triage our septic patients. And so you can use this National Early Warning Score for quite a few different things. We'll use them with patients who might be like opiate naive, or they just look kind of funny. And so what it does is it looks at their respiratory rate, right? And they get a point if they are outside of the normal at all. Okay, we get a point if we're bradypneic, we get a point if we're tachypneic. Okay, if we have low oxygen, we get points. If we need supplemental oxygen, we get a point. Okay, depending on our temperature, blood pressure, heart rate, level of consciousness, so alert. And then this is verbal pain or unresponse, and that's what we need to have some sort of like response to the patient, right? They open their eyes when we talk to them, when we do a painful stimuli, they open their eyes, they're unresponsive. And if it's greater than 5, we want to start thinking that this is a sick patient. Okay, this patient's going to need my continuous monitoring. And I feel like that really doesn't take much, right? All of our patients on supplemental oxygen, they're already almost halfway to that 5. Okay, they're sick patients. And so we can implement this score outside of sepsis, right? If we're trying to think, should I call that rapid response? Should I not? If you pull this news up and they're greater than a 5, we're calling a rapid response. Okay, we're notifying the doctor. Something is happening. My patient does not look good. And then there's this one as well, which is a modified early warning score. Looks at the similar things, but it also is going to increase that urine output. Okay, it also tells us how we can intervene, right? We're between a 1 and a 2. Okay, a few things are off. Let's go talk with our charge nurse. Let's go get some advice from somebody else that we are working with. All right, is it a 3? We need to be observing them a little bit more closely. Okay, and again, I'm going to go talk with my charge nurse. If they keep deteriorating or they're scoring more than a 4, we need to be calling the doctor. Okay, something catastrophic could happen. All right, and this lets us see early warning systems. Okay, so if we think somebody has they're breathing 22 times a minute, that is giving them 2 points. Tachycardic, 4 points. All right, we're already halfway there. We're calling the doctor. Okay. And then, now, for sepsis, okay, determining between sepsis and SIRS. So sepsis is going to have a confirmed or suspected infection, as well as our SIRS criteria. Febrile, hypothermic, tachypnic, tachycardic. They have elevated white blood cells or low white blood cells. And if we think like our elderly population might not mount a white blood cell count, but if their white blood cells went from 6 to 11, that's a big enough jump that I would think that they have some sort of infectious process going on. And then also, right, if they have a low CO2. We can also look at a procalcitonin, which just tells me kind of there's a general bacterial infection going on somewhere. An ABG is going to tell me my CO2. Okay, it's going to tell me if I'm acidic or not. Can also tell me if we have like a pH. That's what I'm worried about with my ABG. Sedimation rate, so that measures how long it takes like red blood cells to go from the top of a sample to the bottom, and it kind of just tells us like how much gunk is in the blood. So a sed rate can be high with inflammation. It's not very specific to sepsis, but it can kind of be an indicator if we have a lot of inflammatory process going on. Same with our CRP, but it's a little bit more specific to inflammation than a sed rate. Blood cultures, if we suspect sepsis, we're getting 2 blood cultures within the first hour of their symptoms starting and before we start our antibiotics. And then also we want like a health history. Were they outside shoveling dirt without any shoes on? Okay, then we are going to be thinking maybe a bacterial or a fungal infection. Okay, in our imaging, right? CT scan, see if we have any inflammation anywhere. So 2 criteria plus a confirmed or suspected infection, right? Somebody comes in with a fever, tachypnic, and they have a chronic UTI. I'd be thinking sepsis. Severe is 2 SIRS things, so they are febrile and they're tachycardic at 110. They have a decrease in urine output, which would be my signs of end organ damage. Or other signs of end organ damage are confusion or decreased urine output, or abdominal pain and constipation, diarrhea, nausea, vomiting. They're more sleepy than usual. Tachycardia, hypotension, those are signs of end organ damage because our heart's not working appropriately. Okay, we are going to have an unstable blood pressure and an elevated lactic. And then severe sepsis are similar symptoms, but it's persistent, right? We gave that liter fluid and our patient isn't getting better. Okay, we are in shock. Not good. We can prevent this from happening if we intervene here. If we recognize it here. Okay, so MODS is a result of decreased oxygen to our organs, right? Cells are going to die, so that's apoptosis is when cells die. We have damage to our vascular endothelium, which is going to cause inflammation, increase capillary permeability, cause vasodilation, so then we can't perfuse, right? If we think of like a garden hose and it is now stretched out to the side of a water slide, all right, but our pool is also now empty. We're not getting any fluid moving through those vessels, okay? There isn't enough force, there isn't enough fluid to keep it moving forward. It's going to cause hypotension. Okay, we can also have microvascular damage, which can lead to coagulopathies. MODS can also be increased glucose production, right? So that increased inflammatory response is going to tell our body like, hey, we need all this energy, cause an increase in glucose production, okay, an increase in oxygen demand, and we cannot meet that demand, which is then going to cause toxicity to our mitochondria, right? Our mitochondria are going to become hypoxic. So in order to make ATP, they're going to have to start using an anaerobic metabolism, which results in lactic acid production, which results in our acidosis, which then furthers our inflammation, capillary permeability, vasodilation, which then further causes all of these problems. So what are we going to do? What are we going to do? Prevention, right? This is why we wash our hands. This is why we alcohol swab our IV tubing before we connect to it. Okay, we don't want to give our patients sepsis. This is why we brush their teeth. All right, that's why we suction their little mouth out if they're intubated. We have a 1 hour bundle, and then we're going to do fluid resuscitation. Okay, get our lab work. We need a lactic, we need a white blood cell count, we need our blood cultures, and then antibiotics. So each hour that our 1 hour bundle is delayed decreases survivability by 7%. So let's say our patients, this isn't true, but let's say we recognize sepsis the first hour that a patient arrives. Okay, they come into the ER with abdominal pain. We notice that they have leukocytosis, their lactic's 5, they're febrile. Okay, we notice these things, but we don't start our fluids for 2 hours. That patient's chance of surviving is now 84% or 86% instead of 100. Okay, so think about our patients. Think about they get their labs drawn at 5 a.m. for a white blood cell count. Maybe they're checking a lactic. Okay, they had their vitals done at 6 a.m. At 6 a.m., they were tachypnic at 24. They're on 2 liters of oxygen, and they're tachycardic at 112. Okay, think of how often that happens, right? They were a little tachy. We drew morning labs. We'll wait for morning labs. We get morning labs at 7:30. It has now been 2.5 hours since labs were drawn, and who knows since this patient became tachycardic because we didn't do vitals until 6. That's why recognition of sepsis is so important, okay, in assessing our patients. Check a lactate, okay, within the first hour. Blood cultures. Once we have 2 sets of blood cultures from 2 different areas, we start our antibiotics. We're going to start with broad spectrum. So usually vancomycin and zosyn, unless they have a penicillin allergy. And then as we get our blood culture results back and we realize what microbe is causing this, then we will change our antibiotics, okay? And then rapid fluid resuscitation. We are going to do 30 mils per kg. We have 3 hours to get that 30 mils per kg ended. Okay, we start it within 1 hour, end it after 3 hours. Okay, so you have 2 hours since recognition to give all of these fluids, right? You don't have to slam all of the fluids in. You can give them in over 2 hours. If we do not have a response, so we do our 30 mils per kg, right? We don't have a response, then we are going to start vasopressors, right? Our vasopressors are our norepinephrine or our levophed, vasopressin, which is vasopressin, or epinephrine, which is epinephrine. Okay, and generally in that order as well. When we give fluids, we try to like a balanced crystallite if we can over normal saline. So like lactated ringers are preferred over NS, but really we just got to get some fluids into them. Okay. So here it is, right? Our patient we've noticed is tachycardic, hypoxic, their white blood cell counts up. What are we going to do? Okay, we're going to get a lactic, we're going to get some blood cultures. While we're doing this, all right, we're also going to start our antibiotics, get our fluids going, okay, and then our pressors if we need to. You can ask for help to get all of these things done, all right? Generally, we're going to get 2 IVs. We can draw our blood cultures off of those. If you don't know how to draw blood cultures, have lab come in and do it so we don't contaminate them, which can totally alter our patient's course of treatment. And so here is more information about our 1 hour bundle. So sepsis is our problem, 1000%. Okay, shock is present, we're going to give our antibiotics. Even if it's not present, we're going to give our antibiotics. If we don't know if it's sepsis or not, okay, then we can kind of hold off, all right? Sepsis, so this would be more of like in surge, okay? If we have a definitive infective process, then we know we have sepsis. And then our goal, again, is a MAP of 65, and then our norepinephrine or our levophed is our choice. So, our assessments, okay? Everything we need to do to get our 1 hour bundle started. And then we are going to assess our patient's level of consciousness. Are they getting more lethargic and sleepy? Or are they starting to kind of wake up? All right, are we getting better or worse? Or are they staying the same? Okay, if they're staying the same, then we know we're still not perfusing very well. What's the respiratory effort? Are they needing less oxygen? That's a good thing. More oxygen? That's a bad thing. Staying the same means their intervention isn't working. Okay, are they starting to develop crackles? Are we giving them too many fluids? If they start to develop crackles and they're still hypotensive, then we definitely want to think about going to a vasopressor. Okay, we don't want to fluid overload these guys because then we have heart failure on top of sepsis. Okay, assessing our oxygenation. How much oxygen are they on? And then assessing circulation, right? We don't necessarily have to have a blood pressure to know how our patients are circulating. We can check our extremities. Okay, do they have signs of mottling? So do they have like little black purple spots on their arms and legs? That's not a good sign. We don't like to see mottling. Okay, do they have a cap refill greater than 2 seconds? Do they have weakened thready pulses versus pulses that are 2+? Do I have weakened thready in my dorsal pedis, but my femoral pulse is 2+? Okay, that tells us how our patient's circulating. What does their skin look like? Okay, are they cool and clammy or are they hot and dry? All right, and then long-term treatment. So we used to give all of these patients steroids. We don't do that anymore unless they are showing signs of like an adrenal shock. We also, if our patients aren't showing signs of improvement, then we need to bring in like palliative care and start talking about withdrawing care, right? What is the goal? What are the outcomes looking like for this patient, right? Do they want to go home and not be able to play with their dogs, not be able to fish on the river, right? What matters to them, and can we get them there realistically, or do we need to look at more comfort measures? And then education, education, education. Okay, if they've been septic once, they can be septic again. How can we prevent this from happening? How can we educate family to prevent this from happening? Okay, thank you.